Risk factors for gastric cancer. Smoking plus alcohol, eating smoked food, fish, preservative-rich food, H. pylori, Menetrier disease, gastric reconstruction, true adenomatous polyp, type A and B gastritis. Group A blood group. Most common gastric polyp. Metaplastic polyp causes by H. pylori. Don't increase risk for gastric cancer. Name of classification for gastric adenocarcinoma. Lauren classification. 1. Intestinal. 2. Diffuse. Risk factors for intestinal and diffuse gastric adenocarcinoma. Intestinal environmental, gastric atrophy, intestinal metaplasia. Diffuse familial, type A blood. Gender prevalence for intestinal and diffuse gastric adenocarcinoma. Intestinal, men greater than women. Diffuse, women greater than men. Age for intestinal and diffuse gastric adenocarcinoma. Intestinal, increase incidences with age. Diffuse, younger age group. Histopathology finding for intestinal and diffuse gastric. Intestinal, gland formation. Diffuse, poorly differentiated, more aggressive, signet ring cells present. Spread route for intestinal and diffuse gastric adenocarcinoma. Intestinal, hematogenous. Diffuse, transmural lymphatics. Mutations for intestinal and diffuse gastric adenocarcinoma. Intestinal, microsatellite instability APC gene mutation. P53, P16 inactivation. Diffuse, decreased E-cadherin, P53, P16 inactivation. Name of classification for early gastric adenocarcinoma. Japanese classification. Cancer present above muscle layer only. Means only in mucosa and submucosa. Name of classification for advanced gastric adenocarcinoma. Borman classification. Muscle layer involved. Type 4 of Borman classification and specific appearance seen here. Linitis plastica, leather bottle appearance. Clinical features of gastric adenocarcinoma. Loads, lump, gastric outlet obstruction, repetitive vomit, anemia, anorexia, neodyspepsia, new onset GERD, silent presentation. Atypical presentation of GIT cancer. 1. Sister Mary Joseph nodule. 2. Krukenberg tumor. 3. Blummer's shelf. 4. Virchow node. 5. Irish nodule. 6. Migratory thrombophlebitis. 7. Dermatological condition. What's Sister Mary Joseph nodule? It's palpable nodule in periumbilical area. Shows periumbilical metastasis. MC cancer. Stomach greater than ovarian. What's Krukenberg tumor? It's bilateral ovarian metastasis. Seen in stomach, breast, colorectal cancer. Due to retrograde lymphatic spread. What's Blummer's shelf? Palpable shelf-like mass in the rectuterine pouch of Douglas in females, or rectovesical pouch in males felt during a digital rectal or vaginal examination. Sign of advanced cancer, gastric, pancreatic, or other abdominal malignancies. What's Virchow's node and aka? AKA Troisier sign. Left supraclavicular lane enlargement, due to lymphatic metastasis through thoracic duct. Seen in GIT genurinary causes. Sign of advanced disease. What's Irish nodule? Left axillary lymph node enlargement. Migratory thrombophlebitis aka and seen in which cancers MC? Trousseau syndrome. Pancreatic cancer. What's Trousseau sign? Involuntary contraction of the hand and wrist muscles triggered by inflating a blood pressure cuff above systolic pressure for 3 minutes. Cause. Hypocalcemia. Dermatological atypical presentation of gastric adenocarcinoma. 1. Laser Trelat sign sudden eruption of multiple seborrheic keratoses. 2. Tripe palms, palms of the hands become thickened, velvety, and ridged. Investigation for gastric adenocarcinoma. Diagnosis, endoscopic biopsy, IOC, overall staging, PET court, TNM stage, use. Site, antrum. Most common site of metastatic for gastric adenocarcinoma. Liver by portal vein. Minimum No of lymph node removed in. Gastric cancer, esophageal cancer, breast cancer, colorectal cancer. Gastric cancer 16, esophageal cancer -15, breast cancer 10, colorectal cancer 12. Management for gastric adenocarcinoma. 1. Surgery for primary tumor. 2. Surgery for lane clearance. 3. Chemotherapy. 4. Radiotherapy. 5. Newer modalities. Surgery for primary tumor. Proximal margin 5 cm, distal margin, pylorus to achieve R0 resection. Total gastrectomy followed by esophageal jejunostomy. Surgery for lane clearance. Japanese stations. Total 13 stations. 1 right pericardial 2. Left pericardial 3. Lesser curvature 4. Greater curvature 5. Suprapyloric 6. Infrapyloric 7. Left gastric 8. Common hepatic 9. Celiac 10. Splenic hilum 11. Splenic artery 12. Hepatoduodenal 13. Retropancreatic. Chemotherapy for gastric adenocarcinoma and indication. 5-FU, cisplatin. Indications: lane positive, muscle invasion, bulky lane, T3, T4. Radiotherapy in stomach cancer. Site: stomach bed, to reduce local regional recurrence. Newer modalities for metastatic gastric cancer. 1. PDLI mutation, pembrolizumab AB, nivolumab. 2. HER3-Neu mutation, trastuzumab. 3. S1 chemotherapy, TEGA4 plus 2 enzyme inhibitors, octaracyl and gimeracyl. Overall most important prognostic factors in gastric cancer. Depth of invasion. Most important prognostic factors in operable gastric cancer. Lymph node status. Origin and most common site for GIST, gastrointestinal stromal tumor. Origin: intestinal pacemaker cells of Cajal. MC site: stomach. Types of GIST and their association. 1. Sporadic, 8W Carney's triad. 2. Familial, 8W Carney-Stratakis syndrome. What's Carney's triad? 1. Gastric GIST mutation to succinyl dehydrogenase B and resistance to imtinib. 2. Paraganglionoma. 3. Pulmonary chondroma. What's Carney-Stratakis syndrome? Gastric GIST. Paraganglionoma. Presentation of GIST. Upper GI hemorrhage MC. Abdominal mass. Pain. Perforation. Spread of GIST. 1. Local invasions. 2. Hematogenous, to liver. 3. Lymphatic spread rare, so lane clearance not mandatory. Investigations for GIST. 1. SECT IOC, radiological diagnosis, cause endoscopy can miss GIST. 2. Immunohistochemistry. 3. Biopsy Fletcher classification. Malignancy risk of GIST is assessed based on tumor size, meiotic activity of cells. Most common IHC marker for GIST. CD117, c-KIT. Most specific IHC marker for GIST. DOG1. Treatment of GIST. 1. For benign GIST, surgery, wedge resection, 2 cm margin. 2. Malignant GIST surgery plus imatinib. If imatinib resistant, sorafenib, sunitinib. Most common type of primary gastric lymphoma. Non-Hodgkin B-cell DLBCL type. Management for gastric lymphoma. 1. Chemotherapy, R-CHOP regimen. 2. Surgery, only if residual disease or recurrence. Most common site for MALTOMA. Stomach. What's gastric volvulus? Its twist in axis of stomach. Axis is made by 2 fixed point, cardia and pylorus. Types of gastric volvulus. 1. Organoaxial. 2. Mesenteriaxial. Organoaxial gastric volvulus. Twist occurs along axis line connecting cardia and pylorus. Its horizontal twist, seen in elderly. Mesenteriaxial gastric volvulus. Twist occurs perpendicular to the axis. Its vertical twist, seen in children. Most common gastric volvulus. Organoaxial. It's associated with diaphragmatic defects, rolling hiatal hernia. Chronic symptoms are more common with what type of gastric volvulus? Mesenteriaxial. Clinical features of gastric volvulus. Burchardt's triad. 1. Retching, violent ineffective vomit. 2. Acute epigastric pain. 3. Inability to pass Ryle's tube. Investigation for gastric volvulus. IOC for stable patient, SECT. IOC for unstable, contrast study cascade sign seen. Management of gastric volvulus. Explorative laparotomy. If stomach viable, derotate and gastropexy plus repair diaphragmatic defect. If not, resection and reconstruction. Mass of hair inside stomach, in woman with psychiatric illness is called trichobazor. What's Rapunzel syndrome? If trichobazor have duodenal and jejunal extension. Clinical features of trichobazor. Gastric outlet obstruction, vomit, pain, epigastric mass, early satiety. Management of trichobazor. If small size, removed endoscopically. Large size, surgically removed.